Okay, how we all doing? How was your weekend? Long? It was a long weekend? I feel like I don't
Sure.
normally hear that. Short. See, that's what I feel like I normally hear. I have been up since like 4:45. Tired. Oh, okay. So we left off on slide 25. Whoa. Everybody hear me? Okay.
Yes.
Okay. Let me know if I start cutting out at all. Um, okay, so we left off on drugs affecting the posterior pituitary. Um, our most important and most common medications on this list is going to be desmopressin, most commonly known as DDAVP, and vasopressin. So the therapeutic action and indications is that it produces antidiuretic activity in the kidneys by increasing ADH, which is your antidiuretic hormone. This increases water reabsorption and decreases urine formation. So it is the opposite of a diuretic. Okay. Vasopressin blockers cause the loss of water through urine. This all starts on page 599. So desmopressin and vasopressin are both synthetic forms of ADH. And vasopressin, if you guys know anything about pressors yet, I don't know if you do, but it does a very good job at increasing your blood pressure. So it is also given as a pressor in critical care to vasoconstrict to increase your blood pressure. So most of the time when you see vasopressin, it's going to be in that critical care scenario where your patient needs help with increasing their blood pressure. So the pharmacokinetics, they vary by drug. They're contraindicated in severe renal dysfunction or obviously allergy. And you want to use caution with patients with known vascular disease. Why?
Because it's going to cause more vasoconstriction.
Because of the vasoconstriction and what can happen if you have vasoconstriction that happens severely in a patient that's already compromised with their vascularity. I know, I'm tired. I'm just going to tell you. So with very high vasoconstriction, especially in a patient with vascular disease, even with a patient without, but specifically with patients that have vascular disease, that can increase the risk to ischemia and necrosis of fingers, toes, entire limbs. So that's when you see a patient that is I think I talked about this last week, the lady that was admitted with COVID and she was on pressors, she was on continuous dialysis. She ended up losing all 4 limbs. She was a teacher in Poland. Very sad. She had like 4 kids too. She's still alive. She survived. And she has prosthetics now. She's doing well, but I'm sure she would be doing even better if she had her arms and legs. Also caution with asthma and hyponatremia. So it says that asthma and hyponatremia could be exacerbated by the effects of the drug. Studies have not been conducted to evaluate the safety of these medications when used during pregnancy or lactation. So adverse effects vary by drug. Drug-to-drug interactions, desmopressin and carbamazepine or tricyclic antidepressants. Alcohol, vasopressin and catecholamines because vasopressin has an effect on the catecholamines. And then check potential interactions before administering these medications with really any other medication. So this is when you call your pharmacist and you say, hey, my patient has a new prescription for desmopressin or GDAVP, or hey, we're starting them on vasopressin. Is it contraindicated with any of their other drugs? Okay. So this is taking a closer look at desmopressin. Desmopressin is the main drug to treat diabetes insipidus. So its indication is treatment for neurogenic diabetes insipidus, von Willebrand disease, hemophilia, treatment of nocturia due to nocturnal polyuria in adults. So this is increased urination in adults at night. The action, it has pressor, which means increase blood pressure, right? And antidiuretic effects. It increases the level of clotting factor with factor 8, which is why it's a treatment for von Willebrand disease and hemophilia. The adverse effects include headache, dry mouth, facial flushing, nausea, fluid retention, a slight increase in blood pressure. So with desmopressin, it says a slight increase in blood pressure. With vasopressin, it would be a very much of an increase in blood pressure, which is why it's used as a pressor in critical care. Local reaction at the injection site, water intoxication at high doses. So I don't know if you guys know this or have learned this, but water intoxication is very real. I remember the first time I ever heard of anything like this, I think I was in high school, and there was a radio show that did a like a contest with how much water someone could drink, like in a short amount of time. And I think this lady drank like 2 gallons of water in like 20 minutes, and she died from water intoxication. Because you can't drink that much water without electrolytes that quickly, because your body can't handle so much rapid fluid without the balance of electrolytes in them, because then it causes the cells to swell, and then actually causes them to like burst. And then all of the extra intracellular ions that were in the cell are now outside of the cell, which causes a ton of problems. This is also why babies are not allowed to have water before 6 months old, because their bodies can't regulate the water. So they will die of water intoxication because they can't handle that balance. There's no balance at that age.
I was trying to tell people that they didn't tell me to get my baby water.
No.
She had hiccups. I said, never.
My son loves water more than anything in the world, and I actually took him to the doctors when he was like before a year old, because I was like, he's diabetic, like he's got to have like type 1 diabetes, something's wrong, because this kid drinks water like he's never drank water before in his life. That's all he wanted, and everything was fine. He was fine. He just loves water. But I was really scared, and I had to literally limit his ounces of water until he was over a year old, because kids can't handle, or babies can't handle that much water. So the nurse is caring for a 10-year-old patient with growth hormone deficiency. The child asks the nurse how long they will need to take the medicine. Which of the following is the best response? So we talked about this last week.
See,
So it's all about the epiphyses, right? So the child taking this drug will need to have pre-therapy and periodic tests of thyroid function, blood glucose levels, glucose tolerance tests, and tests for growth hormone antibodies because they're at risk for developing antibodies, remember? And in addition, you want to make sure you get x-rays throughout the process of the long bones because they need to monitor for when that epiphyses close. Because what happens when they close? There's no more growth. The growth stops in the long bones. Okay. Oh, that's it? Okay. Well, we're going to get more into diabetes insipidus and desmopressin. Shortly. Okay. All right, so adrenocortical agents, these are widely used to suppress inflammation and the immune system. They do not cure inflammatory diseases. Steroids do not cure really anything. They just suppress things. So they may be used as replacement therapy for people with adrenal insufficiency. And not used as long-term therapy if there are safer alternatives, because it's not safe to take corticosteroids for an extended period of time. Now, remember, it's always going to be risk versus benefit when it comes to all drugs, right? So if you have a patient on chronic corticosteroids, it's for a reason. It's because there is no other alternative. But if there is, it really should be suggested to switch to a safer option. So the adrenal glands, we discussed this last week. They sit on top of the kidneys. You have two parts of the adrenal glands. First is the adrenal medulla. So there's an inner core. It's part of the sympathetic nervous system. And then the outer shell is the adrenal cortex, which produces corticosteroids. So the adrenal glands support and control the diurnal rhythm, which that is on page 607. Responds to adrenocorticotropic hormone, which is ACTH, released from the anterior pituitary. ACTH in turn responds to corticotropin releasing hormone, which is CRH, released from the hypothalamus. This happens regularly during a normal day in what is called the diurnal rhythm. Wakefulness will produce high levels of CRH during sleep, usually around midnight. A resulting peak response of increased ACTH and adrenocortical hormones occurs sometime early in the morning around 6 to 9 a.m. This high level of hormones then suppresses any further CRH or ACTH release. The corticosteroids are metabolized, excreted slowly through the day, and fall to low levels by evening. So remember we always talk about, well, you've heard, I'm sure, about your circadian rhythm, right? And when people work night shift, their circadian rhythm gets all jacked up. When you have older people that are asleep during the day, that are up all night, their circadian rhythm is all jacked up. So when we're talking about the diurnal rhythm, it's the same type of concept, but it has to do with the hormone production is not happening at the correct times in the day. So this is why when we're fresh new nurses and we're so eager to work and make that bonus money at the hospital, and your nurse manager is like, well, I need day shift this day and night shift this day and day shift the next day and night shift 2 days from now, and you're like, yeah, there's a $40 extra an hour bonus. Guess what? You're really screwing with your diurnal rhythm and your circadian rhythm. And that's why night shift nurses that bounce back and forth have such a hard time regulating. Okay. It sucks. So you also have activation of stress reaction through the sympathetic nervous system, which bypasses usual diurnal rhythm. So if you have an increase in cortisol, right, which is your stress response, when people have high cortisol levels, it can mess with your diurnal rhythm, your natural diurnal rhythm. So the hormone actions, it's increasing the blood volume with aldosterone, because aldosterone helps us hold on to our water, hold on to our sodium, and hold on to our potassium, right? Causing the release of glucose for energy, and increasing protein breakdown, metabolizing fatty acids into the plasma, decreasing the activities of the inflammatory and immune system, which preserves energy. So I have a star on table 36.1 on page 608. This is Cushing's versus Addison's. I need you to know the difference. I need you to know this table. So adrenal excess, when there's too much, it results in Cushing's disease. This can result from adrenal hyperplasia. Remember, we talked about hyperplasia versus malignancy. Hyperplasia is just when the cells are really big, they're too big, they're bigger than they're supposed to be, right? They take up more space. So it can result from adrenal hyperplasia, which is benign, or a tumor, which could be malignant. An ACTH secreting hormone or secreting tumor, early sign of excessive administration of exogenous, today's going to be a day, exogenous steroids. So if you give people too much steroids, okay, so this can result from either a person that has a big fat adrenal gland, which is from hyperplasia, a tumor in the adrenal gland, an ACTH secreting tumor, which is very similar to just tumor, or you gave your patient way too many steroids, okay, so which can mimic the effects of Cushing's syndrome. So if you
Ms. Simmons,
yeah,
I'm sorry to interrupt. Can you let Veronica in?
yeah, I see that now. Thank you so much.
Yep.
So if you look at this chart, you have Addison's on the left, Cushing's on the right. Cushing's disease, disturbances, cardiac hypertrophy, hypertension, thin, wrinkled skin, purpura, purple abdominal striae, which is like stripes, hirsutism, which is hair growth where it shouldn't be, right? Hyperglycemia, hypokalemia, hypernatremia, osteoporosis, renal calculi, amenorrhea, moon face, buffalo hump, obesity, immune and inflammatory suppression, risk of gastric ulcers and bleeding. These are all signs of Cushing's disease. I need you to know these. Okay? So then you have the other side, the complete other side of the spectrum is adrenal insufficiency. So this can occur if a person does not produce enough ACTH. To ACTH when the gland is damaged, secondary to surgical removal. So if you have to have a kidney removed and the adrenal with it, or prolonged uses of corticosteroid hormones. And this results in Addison's disease or mimicking Addison's disease when it's prolonged use of corticosteroid hormones. So if you look at that chart, on the left side, you have confusion and disorientation, hypotension, arrhythmias, cardiovascular collapse, loss of extracellular fluid, hyperpigmentation, which they say that it looks like a bronzed skin. So not really jaundice, more like bronze color, okay? Sparse axillary and pubic hair, bluish black oral mucosa. So Cushing's, you have lots of hair. Addison's, you have sparse hair, okay? Hyponatremia, hyperkalemia, hypoglycemia, lethargy, fatigue, weakness. So this is the opposite of Cushing's. Dehydration, fatigue, poor response to stress, limited ability to respond to infection. So hypoadrenal function is Addison's. Hyperadrenal function is Cushing's. There is a picture that I uploaded to Brightspace. There's actually a ton of these like picture thingies that I uploaded to Brightspace. You have one on corticosteroids, you have one on Addison's disease, Cushing's. Actually, let me just there. Oh,
I think they're hard to see.
I tried. I
Just because they're blurry, or at least they come up
Yeah,
blurry
they
on my
are blurry.
laptop.
Ugh,
Yeah.
that looks terrible. Damn it. Oh, this is the actual picture. Oh my God, are you for real right now? I think you. I'm just going to add other pictures to I'm just gonna add better pictures of Brightspace because I didn't realize they were that blurry. And they're really nice. I don't know, to me, to look at. So for Addison's versus Cushing's, I need you to know that table 36.1. So please look at it. So this is the normal controls of the adrenal glands versus the use of exogenous corticosteroids, which means I'm giving you corticosteroids. Okay. So, so when you don't have enough and the exogenous corticosteroids are, there's too many, they can cause the adrenal glands to stop producing and stop secreting. So then you have gland atrophy. So it becomes smaller and not able to work the way that it should. Okay. So this is what it's supposed to look like, where it's supposed to produce its own. It's supposed to be nice, beefy, and juicy. And then if you have a patient that's on long-term corticosteroids that are, it's like suppressing and killing their adrenal gland, this is what happens after a while is you have atrophy. So sites of action of the adrenocortical agents. These just list all of your medications that we're about to go through. So it says budesonide, dexamethasone, hydrocortisone work here in the ophthalmic. Just because they work in the ophthalmic area doesn't mean they don't go to many other areas. Because if you look down here, dexamethasone, hydrocortisone, prednisone, work in multiple places. So corticosteroids include androgens, glucocorticoids, and mineral corticoids. And not all adrenocortical agents are in just one category. So they can cross between cortico and glucocortico, right? They can cross between mineral and gluco. They can cross between androgens, and other steroids. So glucocorticoids, they stimulate increase in glucose levels for energy. So at this point, if you don't know, you should know that when you have an increase in steroid use in your patients, their glucose is going to be higher. They're going to need more insulin if they're diabetic, because the regular insulin that they're taking isn't going to cover their increase in glucose. Okay, so that's an important concept that I want you to know. They cause an increased rate of protein breakdown and decrease the rate of protein formation, cause increased mobilization of fatty acids to be used as energy, and at high levels are able to suppress inflammatory response and the immune response. So this is why we are using these drugs for autoimmune diseases, after organ transplantations, because we want to decrease the immune response. So therapeutic actions, they enter the target cells and bind to the cytoplasmic receptors, initiate many complex reactions responsible for anti-inflammatory and immunosuppressive effects. Hydrocortisone, cortisone, and prednisone have some mineral corticoid activity. So this is where you're kind of crossing those lines of what type of corticoid it is. The indication includes treatment of many inflammatory disorders and of local inflammation to relieve discomfort, used in conjunction with other immunosuppressant drugs to inhibit transplant rejection. This is super important. You want your patients that have had an organ transplant. What is one of the most important things for patient education? Medication compliance. Medication compliance is everything when it comes to organ transplantation, because that's the only thing that's stopping their body from rejecting that organ. And then treatment of some cancers and other disorders and infections. So these are well absorbed from many sites. We saw that picture of the person with all of the different types of steroids and all the different places that it can help. Contraindications are definitely an allergy. You want to use caution in acute infection that's not controlled by antibiotics, diabetics, acute peptic ulcers, pregnancy, and lactation. So why acute infection?
It won't heal.
That's more for the diabetics, but well, yeah. It could be for both. So you're suppressing the immune response. So what is a question as a nurse that if you see your patient walking into the office or at the hospital and they just got a new prescription of a steroid, what would you want to ask your patient? Oh, yeah, allergy, but
It's the basics.
have you been sick recently? Are you sick? So say you have a patient coming in and they need steroids and but it's not steroids for like a transplanted kidney. You know what I mean? It's not something that they need like that, but it's they hurt their knee and the doctor wants to decrease the inflammatory response. This happened to me last year right before my 10K. My dog, my stupid fat dog, ran right in the back of my leg and my knee buckled 2 weeks before my 10K. I was so mad. And the girl at Crystal Clinic prescribed me prednisone before my race because she wanted to decrease the inflammation. Because sometimes the inflammation from an injury actually causes more problems than the injury itself, right? So say that's my situation and I have a cough and a runny nose. Do I want to be taking steroids right now?
No.
No, definitely not. It's going to decrease my immune response. And God forbid I'm already immune compromised, right? So my body is trying to fight something and then I'm suppressing my immune response. I'm going to get really sick. Really, really sick. So adverse effects, children, there is a huge risk for diminished growth. This is more for systemic steroids, so like oral or injected steroids when in children, but it also can be inhaled steroids. There's a systemic adverse effect. If your patient has adrenal insufficiency, how does that work then with asthmatics that are on? So that's when you have to, she asked, how does that work when you have asthmatics and respiratory illness? And that's when you have to think about the risk versus the benefit of the drug, right? So with asthmatics, if the disease process gets so severe, you have severe bronchospasms, severe bronchoconstriction, and what happens then? You can't breathe. So would you rather have an open patent airway in breathing? She said, clicks benefit outweigh the risk button. Would you rather have a patient that can't breathe or a patient that has a little immune suppression, right? Because
I feel like my
usually,
question is though, because you're saying it like decreases their ability to basically fight the infection. So then, how does that even fix the problem if we're continuing like we're having this flare up because of the infection, but then we can't heal the infection because we're on this steroid? That's where I feel like I'm confused.
so think about this. Do you usually have antibiotic support during this time? Yes. And you have to think about, is this an oral steroid or is it an inhaled steroid? Right? So if this is an inhaled steroid, it's working directly within the lung tissue. It's not systemic. Now, if you have severe asthma, then you most likely are on some type of oral steroid. And at the same time, that's where you have to weigh the risk versus benefit. But if you have a severe asthmatic, what is more important, your airway or being sick longer and fighting an infection longer? We need an open airway. An open airway is always going to be the most important thing. That's why we prioritize airway, breathing, circulation. Airway always comes first. So it's a great question, 100% a great question, but this is a really good lesson in prioritizing. Because yes, both are important, but my airway is more important. Does that make sense? Did I answer your question or no?
Yeah, I mean, it makes sense, I guess. But
It makes sense, I guess.
I mean, it doesn't like my son is the one who's severely asthmatic, and
Yeah.
he was put on steroid, but because then it like just keeps the infection going. He ends up admitted anyways, and then they have to do an oral steroid, or not an oral, but an inhaled. So I don't understand the reason for giving him the oral steroid if he's going to end up admitted and having to inhaled anyways.
I'm surprised he's not on an inhaled steroid daily.
He is. He's on 3 inhalers. He takes Dupixent. He does he does all the things. He's just like that severely asthmatic.
Yeah, I'm so sorry for that. That is super scary. And I hope that it's always under control for your son. But at the same time, you always, and like I said, you always have to think about if your son has such a severe asthma response and his bronchospasm is so severe that he literally can't exchange air, then it doesn't matter if there's an immune response or not, because he can't exchange air. And exchanging air, we have to survive. So it's not that he's on so many steroids that it's completely blocking his immune system. It's suppressing his immune system, which sucks, but it's not completely shutting it down. There is a level of steroid use that can completely shut down your immune system, which is what they use for people that need bone marrow replacements or transplants. You have to shut that complete immune response down so it's able, that transplant is able to take over completely. I need tissue. Get up. Bleeding. So the best answer that I can give you is that your airway has to be patent. There has to be an open airway, regardless of the immune response, regardless of hospital admission for infection. So, because eventually he is either going to get antibiotics, if it progresses even worse, he's going to have antibiotics, have antivirals if it's viral, God forbid, be intubated. Hopefully that never happens. That was one of my very first young patients. He was in his 20s and it was an asthmatic, and he ended up being fine, but oxygen exchange is always going to come first. So for drug-to-drug interactions, you do not want to, or you want to be careful when it comes to NSAIDs or alcohol use, potassium depleting agents, vaccines, and anticoagulants. Why vaccines? Because of our suppressed
Well,
immune system. But what if your patient is on long-term steroids? Do you want them to get vaccinated? Yes.
Yes.
Because in the end, those vaccinations are going to end up protecting them from illness. So if you have a patient that's on long-term steroids, I want you to know that if they're on long-term steroids, you still want that patient to be vaccinated. Now, if you have a patient that's on a 2-week stint of prednisone and you're like, hey, you need your flu vaccine, we're probably going to wait until you're done with your oral steroids and then give you your flu vaccine. Okay. Also, when you look at contradictions and cautions for on page 613, it says cautions should be used in the presence of an acute infection not controlled with antibiotics. Not, because then you have no support for your immune system. What are the antibiotics doing? They're supporting your immune system by breaking down the bacteria that's causing the infection, right? So if the antibiotics are not, if your body is not responding to those antibiotics, then you're in trouble, especially when it comes to increased corticosteroids. Patients with diabetes, because of the glucose elevating effects, disrupt glucose control. With acute peptic ulcers, because steroid use is associated with the development of ulcers and perforation. With lactation, because the anti-inflammatory and immunosuppressive actions could be passed to the baby. And in pregnancy, especially the first trimester, because of the potential for adverse effects on the fetus. So this is taking a closer look at prednisone. The indication is that it has replacement therapy for adrenal cortical insufficiency. So are we using it for Addison's or Cushing's?
Addison's.
Addison. Management of various inflammatory and allergic disorders. Hypercalcemia associated with cancer. So if you have malignancy within the bone that is excreting a lot of calcium into your bloodstream because the tumor is breaking down the calcium within the bone, you can have hypercalcemia because it's not supposed to be there. It's supposed to be in the bone, not in the blood. Okay. Hematological disorders, ulcerative colitis. Ulcerative colitis is an autoimmune disease. Acute exacerbations of MS, multiple sclerosis, which is also an autoimmune disease. Palliation in some leukemias. Trichinosis with systemic involvement and COPD exacerbations. Because again, we're talking about airway. So the adverse effects include vertigo, headache, hypotension, shock, sodium and fluid retention, amenorrhea. What is amenorrhea? The absence of a period. So none at all. It's just gone. Increased appetite, weight gain, immunosuppression, aggravation of or masking of infections. So you could have a blaring infection and then you're on high dose or long-term corticosteroids and it's masking those symptoms. And then all of a sudden your patient becomes septic because the symptoms up to now have been masked. Impaired wound healing, mood disturbances, and delirium. I don't know about you guys, but whenever I'm on a steroid, I get anxious. I'm so anxious. I can't even stand myself. But then there's other people that are on steroids that they feel like they're like flying on top of the world. So the glucocorticoids may be used to treat systemic or local inflammation. True or false?
True.
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 We did talk about this, but I just want to make sure, because I have a star next to it. Long-term steroids, we want to monitor for signs and symptoms of infection, always, because it's immunosuppressive. So we always want to be watching our patients that are on long-term corticosteroids for any signs and symptoms of infection. And then do not avoid vaccinations because we need to prevent infections for long-term steroid use. You do not want to give live vaccines though. So what vaccines are live?
MMR, varicella, and nasal flu.
The polio.
Who said that?
I did the polio vaccine.
No, who said the other thing?
I did.
Brandy, say that again.
MMR, varicella, and nasal flu.
These are the most common. right? Polio is a good one, but we don't get vaccinated against polio anymore because it's eradicated. But do we?
We do.
Do we?
Kids do,
Okay.
yeah.
But that's like a baby thing. Okay. Anyways, so you want to be careful with live vaccines. So most of these vaccines are given during infancy, right? And then given as like boosters, right? So you don't really see MMRs, polio, varicella in adults. What do you see in adults when it comes to the live vaccine?
Shingles?
The
Maybe.
intranasal flu. Intranasal flu is a live vaccine and it also has contraindications. I believe you can't give it to anyone over the age of 65. It's somewhere in here. Do not give live vaccines when the patient is immunocompromised because there's an increase of infection. I know I have that highlighted somewhere about the intranasal flu. Someone look that up while I keep going. What are the contraindications for the intranasal flu vaccine? Okay, so we are moving on to mineral corticoids. So mineral corticoids affect electrolyte levels and hemostasis. Aldosterone is a mineral corticoid secreted by the adrenal gland. It causes retention of sodium and excretion of potassium. So when we have aldosterone production within the adrenal glands, we're holding on to water, we're holding on to urine, we're holding on to sodium, and we're excreting potassium. For available mineral corticoids, you have cortisone, fludrocortisone, hydrocortisone, prednisolone, and prednisone. So they all end in isone, other than prednisolone, because that's isolone. But they do end in isone.
Miss Simmons, I have a question.
Yeah.
So prednisone is also a glucocorticoid, whatever that one with the G, and then it's also a mineral cortisone.
Right. So remember, they can cross paths because they can. So if prednisone is a glucocorticoid and prednisone is also a mineral corticoid, then that means it not only affects the hormones and the electrolytes, it also affects the immune response and the
Okay, thank you.
Mhm. So the therapeutic actions, it increases sodium reabsorption in the renal tubules. It increases potassium excretion. Our indication is the replacement therapy in primary and secondary adrenal insufficiency and the treatment of salt wasting adrenogenital syndrome. So if we have if we have adrenal insufficiency, which is which disease? Addison's.
Addison's.
We can use our mineral corticoids to treat our Addison's disease. Okay? We can use cortisone, prednisone, prednisolone in the replacement therapy of primary and secondary adrenal insufficiency, which is Addison's disease. So these are absorbed slowly, distributed throughout the body. undergo hepatic metabolism and crosses the placenta and enters human milk. So we do not want to give these to pregnant and lactating women. And we also want to be careful probably with severe liver disease. So these drugs are contraindicated in a known allergy. You want to use caution for people that have severe hypertension, heart failure, or cardiac disease, pregnancy and lactation, high sodium intake, and the presence of a systemic infection. Because especially in the drugs that also have glucocorticoid properties like prednisone and prednisolone, right? Because they affect the immune system. So adverse effects are related to increased fluid volume and allergic reactions. Drug-to-drug interactions include barbiturates, phenytoin, rifampin. Rifampin is a tuberculosis drug. We're going to be learning about that tomorrow or next week. Anti-diabetic medications and multiple other interactions may occur. So why anti-diabetic medications? What do glucocorticoids cause when it comes to blood sugar?
The increase of glucose.
Yes, hyperglycemia. So we are always going to be thinking about our patients that are on steroids. We are always going to be monitoring what? Our patients' blood glucose levels. Because what could they need more of? Insulin. So this is looking closer at fludrocortisone. Its indications are for partial replacement therapy in cortical insufficiency conditions, treatment of salt-losing adrenogenital syndrome. Off-label use is the treatment of hypotension. So why are we using this for salt-losing situations, diseases, disease processes? What does it cause the body to do? Retain fluid
Absorb this.
and reabsorb sodium in the renal tubules. So we're automatically increasing our salt. So adverse effects include frontal and occipital headaches, arthralgia, weakness, increased blood volume, edema, hypertension, heart failure, rash, and anaphylaxis. Increased blood volume, edema, heart failure, hypertension. What does that all have to do with?
The increase.
The reabsorption of all the fluid.
The absorption of all the fluid. So, which also comes with the sodium. But when we're thinking about increased blood volume, what are these drugs doing? They're causing our body to hold on to the fluid and not let it go. So we have an increase in blood volume, which is going to lead to edema, which is going to lead to hypertension from increased volume, which is going to possibly lead to heart failure because the heart can't maintain pumping that high of a fluid volume. Mineralocorticoids should be used with caution in a patient with what?
The
The answer is B. So you want to use caution in administering to people with severe hypertension, heart failure, or cardiac disease because of the resultant increased blood pressure, because of the increased fluid volume. Okay. All right, let's take a break. What time are we here till?
30.
1:30?
Yeah.
Let's come back at 11:45. Or 10:45. Silly me. We are going to move on to chapter 37. So this is thyroid and parathyroid. Oh, I didn't share it. Hold on.
Miss Jessica, June was trying to get in. I don't know if you let her in.
I sure did.
Thank you.
Yep, I'm in. Thank you.
Okay. So you have your thyroid, and you have your parathyroid. The parathyroid are just little tiny spots that are attached to your thyroid gland. So it's very, very, very easy to hurt them during any type of thyroid surgery, thyroidectomy, which is very important to know. That you really, really want to avoid and monitor for any situations where your patient that has had a thyroidectomy has also accidentally lost their parathyroid glands. Okay, so that is important. So
Can you repeat that, please?
yes. So something that you want to monitor your patient that has a thyroidectomy, so the removal of the thyroid gland, you want to monitor for the possibility of your patient accidentally having their parathyroid removed with it. It is a complication of thyroid surgery. And we'll get more into that. So the thyroid is a vascular gland with two lobes, one on each side of the trachea. It kind of looks like a butterfly. It's right here in the neck. It produces thyroid hormones T3 and T4. And it also holds calcitonin, which is why it is dangerous to remove the parathyroid. Because calcitonin is a form of calcium. And when you remove this, you could have something called a calcium thyroid storm, where calcium floods your system. And we learned when we did cardiac that calcium has a lot to do with cardiac contractility because there's calcium channels. So it could be very dangerous to your patient to have a flooding of calcium in their body from a thyroidectomy. Also, the cells remove iodine from the blood, concentrate it, and prepare it for attachment to tyrosine, which is an amino acid. So, if you didn't know, iodine is imperative to have within our diets. You will see possibly children or older adults that have non-functioning thyroids because they don't have enough iodine in their diets. This is why we have iodized salt. Table salt is iodized because it is a way that really, if you really want to break it down, our government ensures that we get enough iodine in our diets so that it is added to our food. So, the functions of the thyroid, they regulate the rate of metabolism. The effect, heat production and body temperature. So the thyroid helps with body temperature regulation. Oxygen consumption and cardiac output. Blood volume, enzyme system activity, metabolism of carbohydrates, fats, and proteins. The thyroid regulates growth and development. And any dysfunction will have numerous side effects. So the thyroid is extremely important for growth and development. I mean, how many times have you, especially because most of us, 99% of us are women, have gone to the doctor and we're like, I gained 50 pounds this year, and the first thing your doctor says is, let's check your thyroid. They always want to blame the thyroid for being overweight. That's what they always said to me. And then I had a gastric sleeve and I kept proving to them that it wasn't my thyroid, but they don't care. It's the first thing they say. So, the thyroid hormone control, it's regulated by the anterior pituitary hormone, TSH. So remember we were talking about the negative feedback system for the thyroid. So the anterior pituitary releases TSH. The secretion of TSH is regulated by the TRH. Increased levels of TSH increases production of thyroid hormones. So that is your negative feedback loop. So your anterior pituitary releases TSH. TSH tells the thyroid to make more T3, T4. And that is your negative feedback for your thyroid. I'm pretty sure that was on your list, right? So this is just a picture of your negative feedback system. So your hypothalamus releases TRH, which tells the anterior pituitary to release TSH, which tells your thyroid gland to release T3, T4. When there is an adequate amount of T3, T4, it tells the hypothalamus, hey, we have enough. So the hypothalamus stops making TRH. So it is a complete loop. Types of thyroid dysfunction, you have hypothyroidism, which is underactivity. You have hyperthyroidism, which is overactivity. So your patients that are hypothyroidism, they are fatigued, they have weakness, they have weight gain. They have a, not really bradycardic, but can be in the lower spectrum of heart rate and blood pressure. When you have hyperthyroidism, you have an increase in metabolism, you have weight loss, anxiety, tachycardia, hypertension. So hypothyroid occurs in number of pathophysiological states. So if you have the absence of a thyroid gland, so if someone removes your thyroid, you are automatically going to be in a hypothyroid state, which means you have to be on Synthroid or some type of synthetic thyroid hormone for the rest of your life, which is very important to know. You need to be on a thyroid replacement for the rest of your life if you do not have a thyroid. If you have a lack of sufficient iodine in the diet to produce the level needed of thyroid hormone, remember, I told you, in third world countries where they don't have a lot of iodine, a lot of children and adults will have iodine sufficiency, leading to hypothyroidism, which is also a very big part of children's growth and development. Okay. Lack of sufficient functioning thyroid tissue due to a tumor or autoimmune disease. What is it? Kawasaki's? Is that what it is? What was the other one? What's the other one? Is the... I'm going to think of it. I know somebody in this group has to have it. Some type of... I can't remember what it's called. Huh? Hashimoto's. Yes. Thank you.
Hashimoto's?
Yes. See, I knew somebody was going to have it.
It's me. It's me.
It's me. I'm the problem. It's me. I have one in here too. Hashimoto's is a autoimmune disease when it comes to thyroid function. It causes an attack of the thyroid tissue. And it's really, really hard to deal with. Hashimoto's sucks. It's really hard to lose weight. It's really hard to, not even thinking about like the major things, but things that really affect you every day of your life: fatigue, weakness, weight gain. And yeah, those are just things that are like right in your face that you have to deal with every day that are difficult. Lack of TSH due to a pituitary disease, lack of TRH related to a tumor or disorder of the hypothalamus. So remember, the hypothalamus, with the release of TRH, that's what starts the negative feedback loop. So if there's any disruption within any part of that negative feedback loop, you're going to have a disruption of that hormone production, right? So if there's something wrong with the hypothalamus releasing TRH, nobody's going to tell the thyroid to release T3, T4, right? So it's a waterfall effect. And this is the most common type of thyroid dysfunction. So your symptoms are varied and vague. They're frequently overlooked or mistaken for signs of normal aging, which I believe is why physicians and nurse practitioners are so eager to be like, let's check your thyroid, because before, probably back in the day, these were overlooked because they probably didn't realize how significant the thyroid hormone and thyroid gland were to every process in the body. So I think they're making up for it by blaming everything on the thyroid. On page 624, it says severe adult hypothyroidism is called myxedema, which results in hypometabolic rate and accumulation of non-pitting edema in the connective tissues throughout the body. Myxedema usually develops gradually as the thyroid slowly stops functioning. It can develop as a result of an autoimmune thyroid disease, which is Hashimoto's, viral infection over treatment of antithyroid drugs, or surgical removal or irradiation of the thyroid gland. Patients with myxedema exhibit many signs and symptoms of hypothyroidism. Hypothyroidism is treated with replacement of thyroid hormone therapy. There's also something called a myxedema coma or myxedema crisis, which is when everything is so severely slowed down that your body literally just kind of shuts down. And it's very, very dangerous. I believe we'll go over that in a couple slides.
Miss Simmons.
Yeah.
So yesterday, actually, my one coworker came back from medical leave, and she had been out for 3 weeks because she got her thyroid removed for Hashimoto's, and she had a tumor on it. And I talked to her about it like all day because we're comfortable with each other, and it was like a real life case study, pretty much.
Yeah.
She told me about all the medicines, the side effects. It was really interesting.
It's scary. It's really scary. One of my best friends had her thyroid removed because she had a huge goiter. She was hyperthyroidism. And I mean, you could literally see it like bulging out of her neck. Her goiter was so big. Yeah. Thyroid disorders are nothing to mess around with. They're very serious.
And then I have a question about it too.
Yeah.
Hyperthyroidism, is it common to have that but like not have a noticeable goiter?
Yes.
Or like, is that possible?
Just because you have
Okay.
hyperthyroidism doesn't mean you will automatically have a goiter.
Okay, yeah.
Okay, so hyperthyroidism is the excessive amounts of thyroid hormones that are produced and released into the circulation. Graves' disease is the most common cause. A signature sign of Graves' disease is eyes bulging. I remember when I was little, my mom would get mad. Her eyes would literally like bulge out of her head. I'm not kidding, like literally eyes bulging out of her head. And then she was diagnosed with Graves' disease, which now is funny looking back, but it was like super traumatic as a child because I thought her eyeballs were gonna pop out. Treatment is the surgical removal of the entire or parts of the thyroid and or drug treatment.
So how does one accidentally take out that other part that you were talking about?
I'm going to tell you.
Is it so small? Okay.
Surgically.
They're really close to each other.
They're extremely close to each other. If you look at page 622, it shows you a little teeny tiny picture. Well, it's not a tiny picture, but the parathyroid are these little teeny tiny glands. There's 4 parts, 2 on each side of the thyroid gland, and they surgically look much different than actual thyroid tissue. So it's notoriously difficult to remove the thyroid without accidentally harming the parathyroid tissue. It is a huge complication of the surgery.
I have another question too.
Go ahead.
So, my coworker, she said that when she went to the doctors afterwards, he asked her, he was like, "Oh, did they put your something in your arm?" And she was like, "What are you talking about?" Looked at her arm. She was like, "No, there's no scar on my arm." Do you know what that was? Like something about the surgery with it.
No, I'd have to look into that. I'm not sure.
Yeah, because she didn't know what he was talking about either.
Well, I'm surprised he didn't go into more detail. Okay, so we are looking at thyroid hormones. We have levothyroxine, which is our most common drug. And the other name for it most commonly is Synthroid. This is synthetic T4. You have another drug called desiccated thyroid. This is prepared from dried animal thyroid glands that contains both T3 and T4. And then you have liothyronine, which is a synthetic salt of T3. So most people with hypothyroidism have a deficiency of T4, which is why they need Synthroid. You don't see the liothyronine very often because, like I said, most of the time it's T4, not T3. So therapeutic actions of your thyroid drugs like Synthroid or levothyroxine, it increases the metabolic rate of body tissues, increasing oxygen consumption, respiration, heart rate, growth and maturation, and metabolism of fat, carbohydrates, and protein. So you're stimulating your body to actually grow and metabolize at the rate that it's metabolizing at. Okay, so you're not over producing, because if you take too much Synthroid, you could send your patient over into hyperthyroidism, right? So when you first start on Synthroid, there's a lot of blood work that happens within that first couple months to try to get the right specific dose for each patient, because every human is different, right? Not every human responds in the same way. So your indications for these drugs is replacement therapy in hypothyroid states, treatment of myxedema coma, which is the severe adult hypothyroidism, right? That myxedema can go into myxedema coma. Suppression of TSH in the treatment or prevention of goiters, management of thyroid cancer, and in conjunction with antithyroid drugs, they treat thyroid toxicity, treat thyroid overstimulation during pregnancy. So these drugs are well absorbed from the GI tract. They're best absorbed when taken on an empty stomach. Does anybody take Synthroid? What time do you take it? What time? 6? Yeah. Yeah. So a lot of people will wake up, take their Synthroid, and go back to sleep. Because you should never take Synthroid with other drugs or other food. It changes the metabolism of the drug and the absorption of the drug. So most of the time, like I said, you will have your patients take this 6, 7 o'clock in the morning. Sometimes they'll go back to sleep. That you don't want to give them these meds with any of their other meds. So it'll be the first thing they do. You teach your patient Put your Synthroid on your bedside table because you're going to wake up, roll over, take your pill, and then do whatever you want to do. Okay.
Is there a reason they wouldn't take it before bed then, since you have all those hours of not taking anything while you're sleeping?
So you can take Synthroid at night. It's not common at all. I think I'm not sure. I think people are more compliant in the morning. And I also think you have to remember that it increases your metabolic rate, so it might inhibit sleep. It might mess with your sleep function. I would have to look into that. That's a good question.
My coworker said that her thyroid medicine for the morning, it like hypes her up a lot. Like it kind of wakes her up.
Which makes sense because it's responsible. Yeah, Aries. Is that how you say it? Aries. Yeah, she just said it.
Yeah.
If she takes it at night, she can't sleep. Okay, so distributed bound to serum protein. So if your patient is malnourished or has low albumin or total protein, you could have an excess in the drug because it's not bound to enough proteins, which means there's a lot of free drug in the bloodstream. So you want to make sure your patient is eating enough, consuming enough protein for their body. Elimination is primarily by the kidneys, but some is eliminated in the feces. It does not cross the placenta, but it does enter human milk in small amounts. Contraindications are for a known allergy, acute thyrotoxicosis, acute MI. So, on page 627, so it says thyroid function tests should be checked annually in long-term therapy to ensure the correct levels are being maintained. Skin reactions and loss of hair are sometimes seen, especially during the first few months of treatment in children. Symptoms of hyperthyroidism include anxiety, tremors, weight loss, palpitations, tachycardia, chest pain, sweating, may occur if the dose is too high. Some of the less predictable effects are associated with cardiac stimulation, which can include arrhythmias and hypertension. Central nervous system effects include anxiety, sleeplessness, headache, and difficulty swallowing and esophageal atresia, which taking the drug with a full glass of water is strongly recommended to alleviate this effect. It also says under clinically important drug-to-drug interactions that increased insulin and digoxin could be required with concurrent use of thyroid hormone replacement. The effectiveness of oral anticoagulants is increased if they are combined with thyroid hormone. Because this may lead to increased bleeding, the dose of the oral anticoagulant should be reduced and the bleeding time checked periodically. That sounds important. That sounds important to me.
Can you say that one more time?
That's on page 627. The effectiveness of oral anticoagulants is increased if they are combined with thyroid hormone, because this may lead to increased bleeding. The dose of oral anticoagulant should be reduced and the bleeding time checked periodically.
Thank you.
Mm-hmm. It says also you want to use caution with hypoadrenal conditions such as Addison's disease. And there is dosing recommendations for older adults. I don't know if you guys have heard of, it's called the Beers criteria, which is a list of medications that can be toxic to the elderly geriatric population, is harmful to kidneys, liver, and may need decreased dosing because of increased age. So that's something important for consideration for older patients. Huh? That's not on, I don't know if it's in the book. That's just from my. Adverse effects, there are few, if any, when the correct dose is used. You could have skin reactions, loss of hair, which I just talked about on page 627. Symptoms of hyperthyroidism if the dose is too high, which we just talked about on page 627. And less predictable effects, which include cardiac, CNS, and difficulty swallowing, which they call esophageal atresia, which we just talked about on page 627. Also, insulin and anticoagulants, we literally just talked about on page 627. So this is taking a closer look at levothyroxine, which is Synthroid. So the indication is the replacement therapy in hypothyroidism, pituitary TSH suppression in the treatment of euthyroid goiters. Goiters is that big enlargement of the thyroid gland. And also this could be hyperplasia. It's not always malignant. It could be benign or malignant. One of my friends that had their thyroid removed, hers was benign, but it can be malignant. So adverse effects include tremors, headache, nervousness, palpitations, tachycardia, allergic skin reactions, loss of hair in the first few months of therapy in children, diarrhea, nausea, vomiting. Most of the adverse effects are from hyperthyroidism. Right? So it said there's not a lot of adverse effects if the dose is correct, because that means that your body and your metabolic rate are actually working at what it's supposed to be. So you shouldn't have a lot of adverse effects if the dose is correct. So then we are moving on to anti-thyroid. So any questions on thyroid replacement? Okay. So then you have anti-thyroid agents. The therapeutic action of thiamides prevent formation of thyroid hormone within the thyroid cells, lowering the serum level, also partially inhibiting the conversion of T4 to T3. So it's lowering the amount of thyroid hormone, or really just preventing. And then you can also have iodine solutions. High doses of iodine block the thyroid function. So if you don't have enough iodine, it can cause hypothyroidism. If you have too much iodine, it can also block the thyroid function. So it's a very much balanced situation. You don't want too much or not enough. The indication is to block the production of thyroid hormone and to treat hyperthyroidism. So thiamides are well absorbed from the GI tract when and then concentrated in the thyroid gland. There is some excretion in the urine, but it really is concentrated, just stays right there within the thyroid. Iodine solutions are rapidly absorbed into the GI tract and widely distributed and excreted through the urine. So contraindications are known allergy, pregnancy, PTU. PTU is on page, where are you? Propylthiouracil. Propylthiouracil, which is a thiamide drug. They call it PTU for short. It's a lot easier to say than the actual drug name, PTU. If you see it on your exam, it's going to have the name, and then in parentheses, it's going to say PTU. Okay. And they are not for the use in children. So, PTU has been associated with severe liver toxicity and is not recommended for use in children except in rare circumstances where other therapy is not appropriate. They don't really go into any other detail, but severe liver toxicity in children is not a good thing. And then caution in lactation. So adverse effects for thiamides, which include PTU, would be effects of thyroid suppression and GI effects. Iodine solutions include hypothyroidism, iodism, which is too much iodine, staining of the teeth, skin rash, and goiter. There are a lot of drug-to-drug interactions with these, with both of these classifications, and they both look very important. PTU has a drug-to-drug interaction with anticoagulants, theophylline, metoprolol, propranolol, digitalis, which is another word for digoxin. Iodine solutions have a drug interaction with anticoagulants, theophylline, digoxin, metoprolol, propranolol, foods high in iodine. So you would want your patient to not have a diet high in iodine. Antithyroid agents, methimazole is also in the same category as PTU. They're both thiamides. So this is for the treatment of hyperthyroidism. The adverse effects, paresthesia, neuritis, inflammation of the neurons, vertigo, drowsiness, skin rash, urticaria, skin pigmentation, nausea, vomiting, epigastric distress, nephritis, inflammation of the kidney, bone marrow suppression, arthralgia, which is joint pain, myalgia, muscle pain, edema. And then if you're also looking at the iodine solutions, this is also for therapy for hyperthyroidism and thyroid blocking in radiation emergency. And the adverse effects would be rash, hypothyroidism, goiter, swelling of the salivary glands, iodism. Iodism has its own adverse or symptoms, which include metallic taste, burning mouth and throat, sore teeth and gums, head cold symptoms, stomach upset, and diarrhea. So having a condition of iodism also has its own signs and symptoms. In which of the following ways does the thyroid gland use iodine? B, to produce the thyroid hormones. So the thyroid gland uses iodine to produce thyroid hormones that regulate body metabolism. Control of the thyroid gland involves an intricate balance between TRH, TSH, and circulating levels of thyroid hormone. Why isn't this charging? There we go. Okay. So we are moving on from the thyroid to the parathyroid. Questions on hypo and hyperthyroidism. Do I want you to know the difference? Yes. Do I want you to know the difference in the signs and symptoms? Yes. Do I want you to know the special little things about the drugs that treat those conditions? Yes. Okay, so the parathyroid glands are 4 very small groups of glandular tissue located on the back of the thyroid gland. They produce PTH, which is the parathyroid hormone. The actions of PTH: stimulation of osteoclasts or bone cells to release calcium from the bone. Remember, I told you there is a possibility when there is a removal of the thyroid that the pituitary gland could accidentally be removed, which can cause a calcium storm, thyroid storm. This is very dangerous for your patient. Increased intestinal absorption of calcium, increased calcium reabsorption from the kidneys, stimulation of cells in the kidney to produce calcitrol, the active form of vitamin D, which stimulates intestinal transport of calcium into the blood. That's a lot of calcium moving suddenly if this gets disrupted. So PTH, is released when serum calcium levels are low. The release is blocked when levels are high. PTH and calcitonin work together to maintain the balance of serum calcium levels in the body. And magnesium affects PTH secretion. So because magnesium and calcium are teeter-totters, so if you have high magnesium, you have low calcium. If you have high calcium, you have low magnesium. Okay. So this is talking about ways that the calcium is where it's used in the body. So the parathyroid hormone works within the kidneys. It works within the bones, and it works within the thyroid and parathyroid glands. Hypoparathyroidism is the absence of PTH, most likely to occur with accidental removal of the parathyroid glands during thyroid surgery, which I've said multiple times. The treatment is calcium and vitamin D therapy. For hyperparathyroidism, this is excessive production of parathyroid hormone. This can occur as a result of a parathyroid tumor or certain genetic disorders, and can be primary or secondary. Paget's disease is one of those disorders. It is a genetically linked disorder. It is overactive osteoclasts eventually replaced by enlarged and softened bony structures. So these are literal overgrowths of bones. If you look at Paget's disease from a long time ago, you'll see patients that have bony growths all over their body. Their heads, their face, their arms, their legs. Obviously, anywhere that you have 206 bones within your body, you could have these protrusions because they're overactive osteoclasts. Osteoclasts are the bone cell that produces bone. Okay. So with this disease, they have deep bone pain, headaches, hearing loss, cardiac failure, and bone malformation. So deep bone pain because it hurts. Bones are especially the inside of your bone, that soft, spongy matrix is very vascular. Okay. Headaches, it's because of the bony prominences that are not only growing outward, but can also grow inward. Your skull is very vascular. Hearing loss, we hear with the bones in our ears. If you are missing a bone within your ear, you could have either no hearing or decreased hearing because they work from the vibration that occurs between those bones in your ears. So if those bones are malformed, you're not going to hear correctly, or you could lose all of your hearing. You have postmenopausal osteoporosis. Dropping levels of estrogen allow calcium to be pulled out of the bone, weakened and honeycombed bone structure. So usually your bone is very thick and strong, and it only has that spongy matrix inside. With postmenopausal osteoporosis, where it's literally leaching the calcium from your bones, the outside of the bone, where it's supposed to be strong and structured and not have holes, has a honeycombed bone structure. The hormone PTH plays a role in maintaining the balance of serum calcium levels in the body. I would hope you know the answer to this. I think everyone's still writing. It is true. It is very true. So this is true. The hormone PTH and calcitonin work together to maintain a delicate balance of serum calcium levels in the body, and also to keep serum calcium levels within the normal range. We have a couple stars coming up. Anti-hypocalcemic agents, recombinant human PTH. There is a drug called Boncity, because I can't say the other word. Forteo. I feel like I've definitely seen commercials for that. Forteo. It increases bone mass in postmenopausal patients with primary or hypogonadal osteoporosis who are at high risk for fracture. Hypogonadal. What did I tell you to remember about gonads? Gonads.
Is that like the adrenal glands?
No. Gonads are your sex hormones. Gonads refer to your sex organs. We just talked about estrogen leaching the calcium out of the bones. So, these drugs cause an increase in bone mass in patients that are postmenopausal, that have to do with their hormone levels that are leaching the calcium. And then there is a synthetic parathyroid hormone called Natpara, which controls calcium levels in patients with hypoparathyroidism. I don't really need you to know either of those drugs. It is important for you to know what PTH does, what it's responsible for, and what happens when you don't have enough. I do, however, would like you to know what calcitrol is, and it is synthetic vitamin D, which is used to manage hypocalcemia. Calcitrol is a very common medication, especially in our older adults. We have a PTH-related peptide. I also don't need you to really know anything about this, but it is for the treatment of patients with high risk of fracture due to osteoporosis. So this is a drug. Who is most at risk for osteoporosis?
Older people,
Older
Older
women
women over 60.
Older,
over 65.
specifically women, specifically white women. That's important to know. So if you had a situation where you had a patient that was 65, small stature, Asian, or you had a patient who was 45, petite, and white, who is at higher risk for osteoporosis? The second one. Why? She has 3 risk factors. The other one, even though she has an increased age, only has 2 risk factors. Can you have osteoporosis and be Asian? Of course you can. It's just we're talking about risk factors, which is the majority of people, right? Where we see it the most. Okay? All right, so the therapeutic action of vitamin D compounds, they regulate absorption of calcium and phosphate from the small intestines, mineral reabsorption in the bone, reabsorption of phosphate from the renal tubules. The drug that I couldn't pronounce, what was it? Boncity, stimulates new bone formation. You have the parathyroid hormone, which acts as a replacement for missing PTH. And then the other one that I can't pronounce acts to increase bone mineral content to strengthen the bone. If you are trying to increase your calcium in your body, what are you now at risk for? What happens when you have too much? What is that called?
Hyperkalemia?
So
No, I mean
You're almost had it.
calcemia.
Hypercalcemia. So specifically with calcitrol, you are at a higher risk of hypercalcemia with that drug specifically. Indications is management of hypocalcemia in patients undergoing chronic renal dialysis, treatment of hypoparathyroidism, and then other drugs. Others are specific to each drug. Our pharmacokinetics vary by each drug. They are contraindicated with allergy, of course. We want to use caution in pregnancy, history of renal stones, lactation, and higher osteosarcoma risk. If you are taking a drug that is increasing the rate of bone formation, if you're taking a drug that increases the rate of anything, you are at a higher risk of cancer formation. Because cancer occurs when something goes wrong within cell production, right? Something within the DNA in that cell has gone rogue. And it said, I'm going to multiply as fast as possible. And then boom, you have a tumor. Okay? So if you have a drug that is increasing the rate of bone formation, you are going to be more at risk for bone cancers, bone tumors, which are called osteosarcomas. Okay. Higher risk of renal stones. What are kidney stones mostly comprised of? Calcium. Calcium deposits within the nephrons, within the glomeruli. Okay. Last slide, and then we're going to go on break. Or lunch. Yeah, lunch. Sounds good. Adverse effects include GI effects, CNS effects. Patients with liver or renal dysfunction may experience increased level of drugs and or toxic effects. Hypercalcemia, especially with calcitrol. An interruption of treatment of severe hypocalcemia. Drug-to-drug interactions will include magnesium-containing antacids, cholestyramine or mineral oil, and digoxin. So if you take calcitrol with cholestyramine or mineral oil, it will reduce the absorption of the calcitrol. Digoxin toxicity can occur with hypercalcemia. If combining these drugs with digoxin serum levels and serum calcium levels should be monitored closely. So we've talked about, especially with digoxin, that if you are hypokalemic, you are more at risk for dig toxicity. Well, you also can be at higher risk for dig toxicity with hypercalcemia. Okay. Okay. Let's go to lunch. It's 11:37. Let's be back at 12:05 and finish up these chapters. Okie dokie. Okay, so this was just taking a closer look at calcitrol, management of hypocalcemia in patients with chronic renal dialysis, management of hypocalcemia associated with hypoparathyroidism. Adverse effects include weakness, headache, nausea, vomiting, dry mouth, constipation, muscle pain, bone pain, and metallic taste. Okay, anti-hypercalcemic agents. These drugs, we have biphosphonates and calcitonin. Biphosphonates are one thing I want you to know about and look at. They are well absorbed from the small intestine. They do not undergo metabolism, excreted relatively unchanged in the urine. Onset of action is slow and duration is days to weeks. And then calcitonins, they have good bioavailability after injections. Both of these, I believe, are injections metabolized in body tissues to inactive fragments that are excreted by the kidney. They do cross the placenta, and it's unknown if it's excreted in human milk. So, did I not? There we go. So on page 639, is where we start talking about anti-hypercalcemic agents. So these drugs are used to treat PTH excess or hypercalcemia. And a common medication for this class is called alendronate, which is Fosamax. There's lots of commercials out for Fosamax. So biphosphonates include Boniva. We've all seen commercials for Boniva too. So Boniva and Fosamax are your most common biphosphonates. These drugs are used in the treatment of Paget's disease and of postmenopausal osteoporosis in females. And alendronate is also used to treat osteoporosis in males. Calcitonins are hormones secreted by the thyroid gland to balance the effect of PTH. Currently, the only calcitonin readily available is calcitonin salmon, which the brand name is Miacalcin. This hormone inhibits bone resorption, lowers serum oh my God. It's ridiculous. In children and in patients with Paget's disease, increases the excretion of phosphate, calcium, and sodium from the kidneys. So, For contraindications, it's on page 639. Alendronate, which is AKA Fosamax. The patient must remain upright for at least 30 minutes. These drugs should not be given to anyone who is unable to remain upright for 30 minutes after taking the drug because serious esophageal erosion can occur. So sitting up for 30 minutes, which is risk of esophagitis and esophageal erosion. That is on page 639. So you want to be cautious with biphosphonates for patients with renal dysfunction, upper GI disease, because it can cause erosion and esophageal inflammation. Calcitonins, you want to be careful with pregnancy, renal dysfunction, and pernicious anemia. So a lot of these drugs are once a week. Some of them are once a month and are given IV. Adverse effects for biphosphonates, most common is abdominal pain, constipation, musculoskeletal pain, nausea, and diarrhea. Increase in bone pain with Paget's disease, esophageal ulceration. We talked about the esophagus a lot with biphosphonates. Long-term use, there's an increased risk of femoral shaft fractures and then osteonecrosis of the jaw, which sounds very scary and very unfortunate. For calcitonin, the most common adverse effect seen with this drug is flushing of the face and hands, skin rash, nausea and vomiting, urinary frequency, and local inflammation at the site of injection. Patients can also have nasal dryness and irritation with the intranasal route. Many of these side effects lessen with time. So these drugs can be given intranasal, IV, EO. There's many different formulations. And all of those are in the table 37.4 where it lists all of the drugs for parathyroid agents. Drug-to-drug interactions for biphosphonates would be antacids, calcium products, iron, multiple vitamins, and aspirin. Biphosphonates should be separated from all medications by at least 30 minutes. It says on page 639. There is an increased risk of GI ulceration if biphosphonates are combined with aspirin. This combination should be avoided if possible. Most people that are taking biphosphonates are over what age? What is biphosphonates for?
Over 50?
For osteoporosis.
Osteoporosis.
So over
Post-
65.
Postmenopausal. When do women most likely go through menopause? In their 50s, right? What do people over the age of 50 usually take every day? Aspirin. So it's probably a huge patient education situation that you want to educate your patients that are taking biphosphonates and also possibly taking aspirin and all the other drugs that they take every day. Calcitonin, if you use calcitonin and lithium, it may lead to the reduction in plasma lithium concentration. Remember, excuse me, we talked about lithium. It has a very small therapeutic window. So things that mess with your lithium blood level serum, it's very important that these patients are educated because people that take lithium need lithium. Okay, we're talking about manic, depressive, bipolar individuals. Lithium is for many other things, but when a patient is very stable with bipolar disorder, you really don't want to rock the boat and put them into a manic or depressive state. All right, so this is taking a closer look at alendronate, which is Fosamax, for the treatment and prevention of osteoporosis in postmenopausal females and in males, treatment of glucocorticoid-induced osteoporosis, and treatment of Paget's disease in certain patients. Adverse effects include abdominal pain, constipation, nausea, diarrhea, increased or recurrent bone pain, and esophageal erosion. What do you want to do after you take a biphosphonate? Sit up.
Stay sitting up for 30 minutes.
Yes, ma'ams. Sit up for 30 minutes. Looking closer at calcitonin salmon, its indication is for Paget's disease, postmenopausal osteoporosis, emergency treatment of hypercalcemia. The most common adverse effect is flushing of the face and hands, nausea, vomiting. There can be local inflammation at the injection site and nasal irritation if it's used nasally. Paget's disease is a genetically linked disorder. It is a condition of overactive osteoclasts that are eventually replaced by enlarged and softened bony structures, which is among the clinical manifestation of Paget's disease. Nobody? The answer is A, hearing loss. Remember, Paget's disease affects the growth of bone growth. So if something is affecting the little teeny tiny bones in your ears, you could lose your hearing. All right. What happened? Oh, sorry. Okay. Agents to control blood glucose levels. So these are your anti-diabetic medications. So the pancreas is an endocrine gland. It is also a exocrine gland. So it's both. Endo means within, exo means outside. So the endocrine produces hormones in the islets of Langerhans. Those are the cells that produce insulin. The
Excuse me, can you let me know what chapter we on?
We just started chapter 38. This is our last chapter. So the islets of Langerhans are the special pancreatic cells that are responsible for the production of glucagon, insulin, and somatostatin. The exocrine part of the pancreas releases sodium bicarbonate and pancreatic enzymes directly into the common bile duct to be released into the small intestine. What does sodium bicarbonate do?
Neutralizes hydrogen.
It neutralizes acid. So if the pancreas is releasing sodium bicarbonate into the common bile duct to be released in the small intestine, what is it doing? Neutralizing acid from where? What is before the small intestine? The stomach. What kind of acid is in the stomach? Hydrochloric acid. Do you really think that it's a good idea for stomach acid to go straight into the small intestine? No. The intestines do not like acid. No, they don't. So what happens is the pancreas has to neutralize that hydrochloric acid before it hits the small intestine by releasing sodium bicarbonate. That is a very important process in our bodies. So insulin is produced by beta cells of the islets of Langerhans. It's released into circulation when the levels of glucose around these cells rise. It reacts with specific insulin receptor sites to stimulate the transport of glucose into the cells to be used for energy. It stimulates the liver to be able to uptake, store, and use glucose. When glucose is stored within the liver, it is called glycogen. When glycogen is used in the liver, it is called glycolysis. So when you are hypoglycemic and your body says, hey, I need sugar, what's going on? There's not enough around here. The liver says, ooh, I need to release glycogen, and it undergoes the process of glycolysis to release glycogen, sugar, glucose within the bloodstream to relieve your hypoglycemia. That is the negative feedback loop for hypoglycemia. Insulin is also released after meals. It circulates and affects metabolism, and it causes blood glucose levels to fall. So when the pancreas says, hey, there's lots of sugar hanging around here, it is going to then secrete insulin. Insulin, remember we talked about all of our doors, our locked doors that surround our cell? Insulin is the key to the door to allow glucose to go inside the cell. We need insulin to unlock the door for glucose to go in the cell. Glucagon is released from alpha cells in the islets of Langerhans in response to low blood glucose. It causes immediate mobilization of glycogen, which is stored where? In the liver, which raises your blood glucose levels. This stimulates the liver to convert proteins into glucose. There's a lot of words here. Adipocytes, adipose tissue is your fat. So fat cells secrete adiponectin. Adiponectin increases insulin sensitivity, decreases release of glucose from the liver, and protects blood vessels from inflammation.
Can you tell me what adiponectin is? I don't, for some reason, that's not registering.
Adiponectin is a hormone that's released from the fat cells.
Okay.
I'm not going to test you on that, by the way. I'm not going to test you on endocannabinoid either, but they are receptors. They seem to be a part of the signaling system to keep the body in a state of energy gain to prepare for stressful situations. The sympathetic nervous system decreases insulin release, increases release of stored glucose, and increases fat breakdown. So that means when you need sugar, when you need energy, the sympathetic nervous system says, hey, this is your fight or flight. It says, hey, I need energy. I need to fight the bear, or I need to run from the bear. If I'm going to fight or run, I need energy. Where do I get fast energy? From glucose. Okay. So the sympathetic nervous system, when it is triggered in that fight or flight response, it decreases the insulin release because we need that blood glucose quickly. We need it in the blood. We need it ready. We need it ready to go. Increases the release of stored glucose, which is in the liver in the form of glycogen, and increases fat breakdown because eventually we can use fat for energy. Corticosteroids decrease insulin sensitivity, increase glucose release, and decrease protein building. This is when we have too much cortisol, too much stress, okay? Our bodies are resistant to insulin. We are becoming less sensitive to insulin. So this can either come in the form of a stress response in the body with increased cortisol levels, or this can come from outside of the body where we have steroid intake, which causes decreased insulin sensitivity, causing hyperglycemia, which is why we need increased insulin, increased anti-diabetic medications while we're taking steroids. Okay? And then growth hormone decreases insulin sensitivity, increases protein building, increases FFAs. But the growth hormone, we need sugar, right, to grow. Our kids, when we're growing and developing, they need that energy for cellular growth. Loss of blood glucose control. We have hyperglycemia, which is increased blood sugar. Glycosuria, which is sugar that's spilled into the urine. Polyuria is increased urination. Polyphagia is increased hunger. Polydipsia, increased thirst. Lipolysis, olysis is the breakdown. Lipo is fats, so this is the fat breakdown. Ketosis is metabolism shifts to use fat for energy. And then acidosis, the liver cannot remove all of the waste products, so our bodies become acidic. We want to make sure we know the 3 Ps: polyuria, polydipsia, polyphagia. Diabetes mellitus, this is characterized by complex disturbances in metabolism. It affects carbohydrate, protein, and fat metabolism. Okay, so clinical signs are hyperglycemia, so a fasting blood sugar level greater than 126, glycosuria, which is the presence of sugar in the urine, and then over the long term, it results in vascular damage, which is where we have peripheral vascular disease, neuropathies, when we have a lot of hyperglycemia. So uncontrolled blood sugar can result in an increased incidence of a number of disorders. That's on page 646. Atherosclerosis can lead to heart attacks, peripheral vascular disease, strokes. Retinopathy is the loss of vision as tiny vessels in the eyes are narrowed and closed. Neuropathy is motor and sensory changes in the feet and legs, and then there's progressive changes in other nerves as the oxygen supply to these nerves is slowly cut off. This is a very common thing that happens to type 2 diabetics and type 1. Nephropathy is renal dysfunction related to changes in the basement membrane of the glomerulus. This is all about hyperglycemia and the vascular changes that occur due to hyperglycemia. Infections, increases in frequency and severity due to decreased blood flow, and altered neutrophil function. And then you have foot ulcers, decreased wound healing due to vascular insufficiency, unnoticed wounds, and infections due to neuropathy, decreasing perception of pain. So what is something that we always tell diabetics when they get into the doctor's office? Take your shoes and socks off. We need to inspect your feet. We want to make sure we look at your feet because they don't feel the pain sensation from the neuropathy. Okay. Another thing you want to educate your patients on is the temperature of their bath water. Because when you first stick your foot in a hot bath, what is your first thing you do? You take your foot out because you feel how hot it is. Your diabetic patients that have severe neuropathy, they can't feel how hot the water is, which can lead to first, second, and sometimes third degree burns. Okay.
We get a lot from using the microwave too. Like they don't realize they'll
With their
heat food
fingers
up or whatever in the microwave.
Yeah.
And they don't realize they grab it out of the microwave and hold on to it, or cups of coffee, and then they'll be blistered and losing a tip of a finger.
Mm-hmm. That is a very good point. On page 647, you have a focus. There's a box 38.2 focus on diagnosis of diabetes mellitus. So, fasting, which is no caloric intake for at least 8 hours, a plasma glucose equal to or greater than 126. You have a 2-hour plasma glucose that is equal to or greater than 200 during oral glucose tolerance test. If you've been pregnant, we all know how that fun glucose drink tastes. A hemoglobin A1C equal to or greater than 6.5%. In a patient with classic symptoms of hyperglycemia or hyperglycemic crisis, a random plasma glucose greater than or equal to 200. So these are all diagnostic ways and tests to diagnose type 2 diabetes. How long does a hemoglobin A1C cover? Is it immediate?
3 months.
3 months. 3 months. So a hemoglobin A1C is your average blood sugar over a 3-month period. So your patient that is a non-compliant diabetic, they have an appointment in 2 weeks and they're like, oh boy, I gotta cut my carbs. That's not gonna help their A1C. The only thing that's gonna help is maybe their fasting glucose, but it's not gonna do anything for their hemoglobin A1C. Which is really nice because most diabetics aren't really that honest when it comes to their blood sugars or how much sugar they're actually getting in their diet. Because it's a hard thing to come to terms with. Diabetes is a scary disease, and most people don't want to deal with it. Oh, we just talked about those. So classifications of diabetes, you have type 1 diabetes, which is caused by an autoimmune destruction of the beta cells in the pancreas, and the patients need insulin replacement. Type 1 diabetics cannot live without insulin. I need you to understand that. Type 1 diabetics cannot live without insulin because their bodies, their pancreas, can no longer support their need for insulin. It can no longer produce the amount of insulin that the patient needs to survive. Type 2 diabetes is the progressive loss of beta cells that release insulin. So decreased insulin sensitivity in peripheral cells also occurs, which we refer to as insulin resistance. Diabetes due to other causes, you could have hyperglycemia due to secondary causes. An example would be medication-induced diabetes. What is a medication that increases your blood glucose? Prednisone.
Prednisone.
Glucocorticoids. Absolutely. Absolutely. And then you have gestational diabetes, which is diagnosed in the 2nd or 3rd trimester of pregnancy. Just because you have gestational diabetes does not mean you are diabetic for the rest of your life. But if you have gestational diabetes, it does put you at a higher risk for developing type 2 diabetes later on in your life. Clinical signs and symptoms of hyperglycemia. I need you to know the signs and symptoms of hyper and hypoglycemia. Hyperglycemia includes fatigue, lethargy, irritation, glycosuria, which is glucose in the urine, polyphagia, polydipsia, frequent infections, poor wound healing. This should also include polyuria. So the 3 Ps, they are clinical signs and symptoms of hyperglycemia: polyuria, polydipsia, polyphagia. Signs of impending dangerous complications of hyperglycemia: fruity breath, dehydration, slow, deep respirations, loss of orientation, and coma. What do we call this? DKA, diabetic ketoacidosis. Most likely, most of the time occurring in type 1 diabetes. The fruity breath is caused by the ketone production. This accompanies dehydration. Deep respirations are also called Kussmaul respirations. And then loss of orientation and coma. This is from severe diabetic ketoacidosis. These patients are absolutely in critical care. Even when you're in DKA, you are in the ICU, which means we are going to cover this heavily in 2851, which is complex care 1. Hypoglycemia is a blood sugar 70 milligrams per deciliter or lower. The initial response is a parasympathetic stimulation, increased GI activity to aid in digestion and absorption to try to increase your blood sugar. Sympathetic nervous.
Ms. Simmons, I have a question.
Yeah.
With the ketones, isn't that like the byproduct when the cells are using fat instead of like, and so why would that be for hyperglycemia if there's like already too much sugar in the blood?
That's a great question. That's a very good question. So who did I tell you was more at risk for DKA? Type 1 or type 2?
Type 1.
Type 1.
Type 1.
What does type 1 not have? Insulin. They don't have insulin. They don't have enough insulin. So what happens to patients that have type 1 diabetes that go into DKA, that means that their blood sugar is so high, they do not have enough circulating insulin to use that sugar for energy. So the patient metabolically starts using fat for energy because they can't use the blood glucose because they don't have insulin. So instead, their bodies need energy. They need energy production. So the body, we are constantly trying to not compromise, compensate. We are constantly trying to compensate, right? So if one part of our body isn't working correctly, it's going to compensate by doing something else. So if a type 1 diabetic can't use the sugar that is circulating within their blood, they're going to kick over to fat metabolism for energy production. The byproduct of fat metabolism is ketones. So when you have a person that is on a keto diet that is producing ketones as a non-diabetic, this is not harmful to their bodies because it has nothing to do with blood sugar and ketones. DKA results from hyperglycemia and the fact that the patient in DKA does not have insulin to use that hyperglycemia, that high glucose for energy. So as a result, the patient will go into a fat metabolism state, which then creates ketones, which is acidic, as a byproduct. Those ketone acids are then spilling over into their urine, which is why a lot of type 1 diabetics, probably 99% of them, have urine dipsticks in their medicine cabinet to test for ketones in their urine, because it is the first sign of DKA. Not the first sign, but it is a diagnostic tool for patients that are type 1 to realize, I'm going into DKA, I need to go to the hospital. Because at that point, it doesn't matter how much insulin they take into their body, they inject subcutaneously, it's not going to get them out of DKA. They need to go to the hospital. And like I said, we are going to cover this in depth in complex care. But does that make sense, at least for now?
Yeah, it makes sense. Thanks.
Okay. We already talked about the sympathetic nervous system responding with fight or flight, breaking down fat and glycogen to release glucose, and the pancreas releases glucagon to increase glucose and somatostatin production. Okay, wait a second. It doesn't even. Okay, so on page 649 in table 38.1, it has a signs and symptoms of hypoglycemia and hyperglycemia. It is important for you to know the difference between the two, the signs and symptoms for both. Page 649, table 38.1.
Would that be C?
Yes. Manifestation of hyperglycemia. Frequent infections. The rationale, hyperglycemia or high blood sugar results when there is an increase in glucose in the blood. Clinical signs and symptoms include fatigue, lethargy, irritation, glycosuria, polyphagia, polydipsia, frequent infections, and poor wound healing. Sites of action of drugs used to treat diabetes. This just shows a lot of drug names that you guys do not know yet. So we're not going to look at it right now. So number one, of course, is going to be insulin. So the therapeutic action of insulin is that it promotes the storage of the body's fuels, which is sugar, glucose. It facilitates the transport of various metabolites and ions across the cell membrane, which means it helps sugar cross the cell membrane into the cell to be used for energy production within the mitochondria in the version of ATP. Remember, we discussed that the first week, okay? It simulates the synthesis of glycogen from glucose, which occurs in the liver, of fats from lipids, and proteins from amino acids. And it reacts with specific receptor sites on the cells, which we talked about, the keys to the locks of the doors on the cells, which let glucose into the cell for energy production. Insulin, the indication is the treatment of type 1 diabetes and also the treatment of type 2 diabetes in adults who have no response to diet, exercise, and other agents. So if everything else fails and your type 2 diabetic no longer has a functioning pancreas, or the pancreas has decrease in function, they may require insulin. Pharmacokinetics, there are various preparations available. There's short and long-term coverage processed within the body like endogenous insulin. And the peaks, onsets, and duration is very, very, very important. If you came to our little tutoring session, you would know that the peaks and onset of insulin is extremely important for your test tomorrow. Contraindications, there's really none. There is inhaled insulin, which is very uncommon. I've never actually seen it or seen a patient that has been prescribed inhaled insulin. But it is contraindicated with people with asthma, COPD, lung cancer, or history of lung cancer, which makes sense. You really don't want to put things in your nose that irritate your airway in people that have reactive airway disease. It is used cautiously in pregnancy and lactation, which if you've ever been diagnosed with gestational diabetes, you know that pregnant women absolutely can take insulin. Adverse effects, number one, 100% of the time is always going to be hypoglycemia. That is your number one adverse effect that you are monitoring for after giving insulin.
I have a question. So for the peak onset and duration of the medication, are we just studying the course book? Because I know we were having issues with them being different.
Correct. I haven't gotten there yet. Jumping ahead of me.
Oh, okay. Oh, my bad.
Anything that you inject into your body, there is always going to be a risk of reactions at the injection site. And then decreased potassium levels. This is very important. I need you to understand this, not only for right now in this moment, but I also, when you get to me in complex care 1 and 2, I need you to understand this concept, okay? Insulin causes extracellular potassium to go intracellular. So the potassium that is in your blood, your serum potassium, 3.5 to 5. When you have insulin injected into your body, either subcutaneously or IV, this causes potassium to go inside the cell, which can then cause hypokalemia. Hypokalemia puts you at risk for what?
Arrhythmias?
Arrhythmias, dysrhythmias, cardiac arrest. Okay. Very, very, very important thing to know.
Sorry, it was hyperkalemia, a risk of hyperkalemia
No,
where?
hypokalemia,
I was trying to
low potassium.
Low potassium. Okay.
Okay.
So just low.
Say that again.
It's just low potassium. Okay, just low potassium.
So
Not anywhere specific.
insulin causes potassium to go intracellular, which is causing hypokalemia.
Oh, okay. Interesting. Okay.
Okay, so clinically important drug-to-drug interactions. Caution should be used when giving a patient stabilized on insulin any drug that decreases glucose levels, which include oral anti-diabetic agents, beta blockers, salicylates, and alcohol. Dose adjustments may be needed when any of these drugs are added or removed. Care should be taken when combining insulin with beta blockers. The blocking of the sympathetic nervous system also blocks many of the signs and symptoms of hypoglycemia. We talked about that on your first exam. Beta blockers mask the signs and symptoms of hypoglycemia. It is important that you know that. You may see it again. Hindering the patient's ability to recognize the problems. Patients may need higher doses of insulin if they are also using thiazide diuretics or glucocorticoids. Patients should also be warned about possible interactions with various herbal therapies. Insulin is a medication that often requires frequent titrations and monitoring due to multiple drug-to-drug interactions. I am going to give you an answer about the onset and peak of the insulin within the hour. Because honestly, I had so much going on this weekend that I forgot that there was a discrepancy between the book and ATI. So I will 100% have an answer for you with. But regardless of that answer, I need you to know the onset and the peak of insulin. Okay? So the difference between regular insulin, NPH, long acting, short acting. I need you to know the peaks and onsets. And you know what I'm going to do? I am going to, whatever answer I get, I am going to upload a chart of those peaks and onsets into Brightspace. Or maybe I'll just email them. I don't know yet, but either way, you're going to be notified. So please look out for that. This is just taking a closer look at insulin. This is on page 653, which originally I wanted you to study these peaks or onsets and peaks. And this is what I previously tested my students on, which because I go by this book, I teach out of this book. So like I said, I will give you an answer on it. Okay, sulfonylureas. They stimulate the functioning beta cells in the pancreatic islets to release insulin. They may improve insulin binding to insulin receptors and increase the number of insulin receptors. They increase the effect of ADH on renal cells. They're effective only in patients with functioning beta cells. So who cannot take sulfonylureas? Type 1 diabetic. Thank you. These may lose effectiveness over time. And second generation sulfonylureas have several advantages over the first generation. So you're going to see the second generation ordered more than the second. Or I'm sorry, than the first. So if you look at page 657, table 38.3, you only have one first generation sulfonylurea, tolbutamide, which, like it says, it is not used. You're going to use your second generation, which is glimepiride, glipizide, and glypuride. So the therapeutic action, again, it stimulates insulin release from the beta cells in the pancreas and improves the binding of insulin, bless you, to the insulin receptors. So it helps the insulin get into the cell, okay? And it also helps insulin production. So indications, it's used in adjunct to diet and exercise to lower the blood glucose level in type 2 diabetes. Off-label use, it is adjunct to insulin and metformin to improve glucose control. They are rapidly absorbed from the GI tract, undergo hepatic metabolism, and excreted in the urine. Glyburide is also excreted via bile, and it has a peak and duration that vary with each drug. Contraindicated, of course, in allergy, diabetic complications. It is contraindicated in type 1 diabetes because the patient has to have functioning beta cells. If you don't have functioning beta cells, you are not capable of producing more insulin.
Miss
Yeah.
Simmons, I tried to look at the transcript, but it doesn't accurately. What were the 3Gs you just said? Glyburide and what?
Glimepiride, glipizide, and glyburide. They're all on page 657 in table 38.3.
Okay, thank you. I'm
No, you're
sorry.
fine. So adverse effects, of course, are going to be hypoglycemia. Any anti-diabetic agent is going to be, the highest risk is going to be for hypoglycemia. GI distress, allergic skin reactions, drug-to-drug interactions include beta blockers, alcohol, and many herbal therapies. We have already discussed why beta blockers are an issue, correct? We all know this? Good. So this is taking a closer look at glyburide. It is adjunct to diet and exercise in the management of type 2 diabetes. It can be used with metformin or insulin for stabilization of diabetic patients. Adverse effect is GI discomfort, anorexia, nausea, vomiting, heartburn, diarrhea, allergic skin reactions, hypoglycemia. So mostly with your anti-diabetic, especially the oral ones, there's a lot of GI adverse effects, a lot. All right, true or false? Second generation sulfonylureas have several advantages over first generation sulfonylureas, including the fact that they interact with more protein-bound drugs.
True.
It is false. The first part is true, the second part is false. So, they do not interact with as many protein-bound drugs as the first generation drugs do, and they have a longer duration of action, making it possible to take them only once or twice a day. So the first generation drugs, they have to be taken more often, which increases the level of non-compliance. Okay. So the next classification is alpha glucosidase inhibitors. So these inhibit alpha glucosidase, which breaks down glucose for absorption. They delay absorption and they assist in lowering A1C levels. They can be used in combination with other drugs that can help lower glucose levels. There's two drugs under this criteria or classification, Archibos and Miglitol. Both of these are PO meds that are taken 3 times a day at the start of each meal. And they are not common medications at all. They're contraindicated in patients with a known hypersensitivity, DKA, just GI disorders, and Archibos cannot be taken if a patient has liver cirrhosis because of the metabolization in the liver. You want to be cautious with renal impairment, GI effects, anemia, and I'm not spending a lot of time on this classification because I'm not testing you on it. Biguanides. Biguanides is important because that includes metformin. What is one of the most common medications that is prescribed in the US of A? Metformin. So the therapeutic action, it decreases production and increases uptake of glucose. It lowers both the basal and postprandial blood glucose levels. What does that mean? Okay, basal. We have something called a basal rate. Your basal rate is the amount of insulin that your body produces on an hourly rate that is just normal. It is just, that's what it is. No matter if you're eating, if you're not eating, if you're sleeping, if whatever you're doing, your basal rate is the bare minimum. That is the bottom line of always excreting this amount. Postprandial means after meals. So it lowers your blood glucose levels postprandial, which means after meals. It decreases hepatic glucose production. So it decreases the liver from performing glycolysis, which means putting glucose in the bloodstream from the liver. It improves insulin sensitivity of the peripheral cells, and it is the first line standard of care for people with type 2 diabetes. It's absorbed orally, it's not metabolized, and excreted primarily in the urine. Absorption and elimination times vary based on the type of formulation. Contraindicated in an allergy, severe renal impairment, and metabolic acidosis. So we do not give this to patients that are type 1 diabetics or are in DKA. Also on page 661, under contraindications and cautions, it is contraindicated in patients with severe renal impairment due to increased risks of side effects, including lactic acidosis. You want to be cautious in patients that have hepatic impairment, excessive alcohol intake, patients that are not eating or drinking due to surgery, undergoing radiologic studies with contrast. Why? Do we know why? Have we ever been taught?
Because it can cause metabolic acidosis.
So
It causes the lactates thing.
Lactic acidosis.
Something with the acidosis. Oh, did I say the wrong
you're
thing?
good. You guys, no, I'm proud. You guys are doing so good. Okay, so on page, it starts on 661 and goes to 662. Caution should be used in administering metformin to people with hepatic impairment who have excessive alcohol intake, who are not eating, blah, 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 who are undergoing radiologic studies with contrast, who are age 65 or older, and who are in hypoxic states due to increased risk of lactic acidosis. If you have to receive contrast for a CT or MRI, you have to withhold metformin for 48 hours, 24 hours before and 24 hours after, which are a total of 48 hours. That is very important. This can result in acute kidney failure. There is a black box warning. This is also on page 662 under adverse effects. There is a boxed warning regarding metformin associated lactic acidosis. This is uncommon but can be fatal. Symptoms include malaise, myalgias, respiratory hyperventilation, somnolence, and severe abdominal pain. What happens when you have a buildup of lactic acid in the muscle and muscle pain? I told you when we were talking about statins, they're rhabdomyolysis. There is a huge warning for rhabdomyolysis with metformin.
I have a question. So what's the one with like stomach distension that'll happen like near death and stuff? Like the word for that. It's something acidosis or alkalosis or something.
Stomach distension? I'm not sure.
Let me think.
Describing it greatly because I'm not sure.
No, that was not a good description.
Okay, so this is looking closer at metformin. This is adjunct to diet and exercise for the treatment of type 2 diabetes in patients older than 10 years of age. With an extended release form, it's used in adult patients, adjunct treatment for PCOS, polycystic ovarian syndrome. The adverse effects include hypoglycemia, lactic acidosis, GI upset, nausea, anorexia, diarrhea, heartburn, allergic skin reaction. The most common reason for non-compliance with metformin is the GI effects. It will make you poo your pants. People have a really hard time with diarrhea. They don't like it. They don't want it. So if you stop taking the drug that causes you to have diarrhea all the time, that is being non-compliant. DPP4 inhibitors, I'm also not going to spend a lot of time on this. I'm not going to test you on this. But these are drugs that are usually injected. So they slow the inactivation of incretin hormones, which is they have to do with the glucose use cascade. It's not a common area. Increase insulin release and lower glucagon secretion, which comes from the liver. It is used in adjunct to diet and exercise to lower blood glucose in patients with type 2 diabetes. So they're rapidly absorbed. They have a peak effect in 1 to 5 hours. They are contraindicated in patients with DKA or type 1 diabetes, and you want to be cautious with renal impairment. They have a rare adverse effect of pancreatitis, heart failure, severe joint pain. Meglitinides are similar to sulfonylureas. They are also used in adjunct therapy to diet and exercise and treatment of type 2 diabetes. They're contraindicated in type 1 diabetes or DKA. Most of these drugs are contraindicated in type 1 diabetes or DKA. Okay.
Miss Simmons. I looked it up and because I had a patient at a clinical before who was at like end of life and it's caused from paralytic ileus and he also had lactic acidosis.
Oh, okay. So here's lactic acidosis is the accumulation of acid, which can put you into metabolic acidosis. So the higher your lactate, the higher your risk for metabolic acidosis. And we're going to learn a lot about this in complex care 1 and 2 when we talk about acid-base balance. But being in a acidic state is very common in people that are critically ill and people that are dying.
Okay, thank you.
I'm also not going to spend a lot of time on this classification. But this classification includes Farxiga and Jardiance. These are also drugs that we've seen commercials on. So they block your kidneys from reabsorbing glucose. They're used in adjunct to diet and exercise in treatment of type 2 diabetes. They have research going in for type 1 diabetes, but I don't think it is approved for anyone with type 1 diabetes yet. Well, it's contraindicated with DKA and type 1 diabetes, so apparently it hasn't been approved yet. Severe renal impairment, because it literally depends on not reabsorbing glucose. So you need renal function to be able to use this drug. Adverse effects include dehydration and hypotension, UTIs and genital fungal infections, DKA. If you have a lot of glucose in your urine, what is yeast really like? Yeast loves sugar. Yeast, when you use yeast in like bread and dough, you have to feed the yeast, and we feed it with sugar. Okay? So if you have a lot of yeast in your urine, you are at a huge high risk for yeast infections, okay, and UTIs. I'm also not going to spend a lot of time on these drugs. They decrease the insulin resistance in peripheral cells and the liver. They increase responsiveness to insulin. They're adjunct to diet and exercise to lower blood glucose in type 2 diabetes. Contraindications for moderate or severe heart failure. And the adverse effects, you could have upper respiratory infections, headache, muscle pains, increased total cholesterol, rapid weight gain and edema due to fluid retention. These are not common medications. The adverse effects are probably too great for this to be a common medication to be prescribed. They interact with insulin, and I don't know what CYP2C8 inhibitors are. This I want you to pay attention to. So, human amylin, the therapeutic action is that it slows gastric emptying, suppresses glucagon secretion from the liver, regulates food intake by modulating the appetite. It is indicated for patients with both 1 and type 2 diabetes who are also treated with insulin. It has a rapid onset and peaks in 20 minutes, and it should be injected before each meal. So, this is on page 666. The drug name is called pramlintide, which is also Symlin, Symlin, Symlin. The contraindications are hypersensitivity and gastroparesis. What is gastroparesis?
Is that like paralyzing? Like not moving?
Yeah, so this is when the stomach becomes paralyzed. This is a really terrible thing that can happen to some people. Also, it happens to people that take GLP-1s like Ozempic or tirzepatide, and is a huge risk because it can become permanent gastroparesis. So it is contraindicated for gastroparesis because what does the drug do? It slows gastric emptying. So If you slow gastric emptying too much, it can cause gastroparesis, which is the paralysis of the stomach. Okay. So caution when starting insulin dosing should be decreased, and an adverse effect is going to include severe hypoglycemia. So like we said, it has a rapid onset of action and peaks in about 20 minutes. There is a half-life of about 48 minutes. It should be injected before each major meal of the day, at least 2 inches away from any insulin injection. I want you to put a star next to this, highlight it. I don't care what you do. I want you to remember it. It cannot be combined in the syringe with insulin. It can never be mixed with anything. Drug-to-drug interactions include Symlin and insulin or other anti-diabetic medications because of the risk for severe hypoglycemia. You also don't want to take this drug with other drugs that slow gastric emptying, like opioids. So this is taking a closer look at Symlin. This is for treatment of patients with type 1 or type 2 diabetes who use mealtime insulin and have not achieved desired glycemic control despite optimal insulin therapy. Adverse effects include nausea, vomiting, anorexia, headache, hypoglycemia, and injection site reactions. GLP-1s, we are going to look at this because what is very common right now, everybody wants to take GLP-1s. So it's important as nurses that we know what is cool and what everybody is taking, okay? So GLP-1s include Ozempic, which is semaglutide. So semaglutide is the generic name. Ozempic is the brand name. And then tirzepatide, which is also known as, it's coming to me. I don't remember the name. Oh, what is it? Zepbound. Oh, that's the weight loss one. Wegovy. Yes, Wegovy. Oops. Okay, so these increase insulin release, they decrease glucagon release, and they slow GI emptying. So this is another medication that slows GI emptying. So what is that putting our patients at risk for? Gastroparesis. You want to This is in adjunct to diet, exercise for people with type 2 diabetes. Some also are used to reduce the risk of major cardiovascular events in people with type 2 diabetes and cardiovascular disease. And we also know that this is very popular right now for weight loss. So most are injected via subcutaneous injection. Contraindications, you don't want to take liraglutide and semaglutide. There's a boxed warning for risk of thyroid C-cell tumors in animals. So if you've ever been a person that has looked into a GLP-1, one of the questions that they ask you, have you ever had thyroid disease or thyroid cancer? Because it increases the risk for thyroid cancer. It is contraindicated in patients with type 2 diabetes or DKA, and it is contraindicated for patients that are pregnant, breast, or chest feeding. A huge adverse effect is pancreatitis. That's probably your biggest one, is pancreatitis. Also, GI effects, which can include nausea, vomiting, decreased appetite, constipation, and diarrhea. There, on page 667 under adverse effects, I have highlighted there is a risk of pancreatitis with these drugs. So they need to be held if the patient reports severe epigastric pain. Glucose elevating agents. These are drugs that increase the blood glucose levels by decreasing insulin release and accelerating the breakdown of glycogen in the liver to release glucose. This is for the treatment of hypoglycemia. They are rapidly absorbed. Contraindications include known allergies to sulfonamides or thiazides in pregnancy. Glucagon, there's no adequate studies on pregnancy. Cautions in lactation, hepatic dysfunction, or cardiovascular disease. These drugs are listed on page 669. Your most common one is glucagon. This can be given subcutaneous, IM, IV. It can also be given intranasal. And also there's glucagon like tablets and gels. So the indication, it counteracts severe hypoglycemia reactions in diabetic patients treated with insulin. Adverse effect includes hypotension, hypertension, nausea, vomiting, respiratory distress with hypersensitivity, hypokalemia with overdose. So, question. If you have a patient that is hypoglycemic, okay, hypoglycemic, your patient, you walk in the room and they are sitting there talking to you and you say, hi, how are you? And they're saying, oh, hi, how are you? And then you test their blood sugar and it's 65. Do you give glucagon or 4 ounces of juice? 4 ounces of juice.
4 ounces of juice.
Because why?
They're conscious.
Because
they can still speak.
They are
everything.
conscious and talking. Okay? When your patient is conscious and able to talk to you and follow direction, you use your least invasive way of reversing hypoglycemia. So you have, and in your MAR on Epic, it will give you a whole list of things to do. It will say, if your patient has a blood sugar less than 70 and is able to swallow and alert and oriented, give 4 ounces of juice. If your patient has a blood glucose level of less than 70 and is incoherent or unconscious, use IV dextrose. If your patient is arousable or arousable but incoherent, you can use glucagon. Okay, so there's different levels of treatment of hypoglycemia. If your patient is alert, aware, able to swallow, and able to follow direction, you are going to give them simple sugar, which is 15 grams of a carbohydrate, simple sugar like apple juice, cranberry juice. That's why they have those little juice packets, orange juice in the hospital. Okay. When are you going to recheck your patient's blood sugar? 15 minutes. And then if your patient is persistently hypoglycemic, you are definitely going to call a provider. Depending on the level of hypoglycemia, you're going to treat accordingly. Okay. Any questions? No questions.
I think I'm just trying to take all of this in still, because this was like a lot of, I looked over it over the weekend, but there's still like quite a bit of information 24 hours before the test.
It's a lot. I know it's a lot. That's why I
have a question
for
sorry,
class on Monday, Wednesday. Yeah, go ahead.
For the NPH, the intermediate, That is the cloudy one. Does that one need refrigerated as well?
Yes.
Always. Is it in a dark container also?
No.
No. Okay. Thank
And
you.
it's the only insulin that can be mixed with another insulin.
Yeah.
What is the only insulin that can't be mixed?
Is it the long acting?
Long acting. And you can't mix Simlin, which I know is it's different than insulin, but you can't mix it with anything. And then what is the only insulin that you can give IV? No.
It's regular.
Regular.
Regular insulin is the only insulin you can give IV.
How many questions will we have on our test?
I think it's 40.
Okay.
Stop sharing the screen.
Is there any way that this lecture is going to be uploaded like before the test?
Oh, yeah.
Because I'm the first half of the class.
Yeah, this will absolutely be uploaded as soon as possible. Yeah.
Okay, awesome.
And I do have a question for you. So I didn't receive a SAP or anything, but I had preset meetings with you to go over exams, and today was one of those days. Are you still available to go over the stuff that was missed on the first exam? Or do you want after the second exam to do it all at once for the final?
Ooh, that sounds like a good idea. Is that okay with you? Because you're not going
No,
you're
it's
not going to
fine.
see anything from the first exam on this second exam. So I think it would actually be more
Right.
beneficial for you if we just did them both before the final on your next one.
Okay, that's fine. So I guess you can disregard. Do you want me to set another meeting? I preset them at the beginning of the class, but or were you just gonna do it all together like you said?
I think I'm going to, oh yeah, a math or
Sorry.
No, it's okay. Because I had so many meetings this past week. And it was really hard to get everything done because I had so many meetings. And I really would like to start clumping them together or just go over them as a class.
I did see the subcategories. They do show you on ATI.
Okay.
So it tells you kind of like down to a T or whatever. But
Good. I really would like to go over them as a class. I just need time. I need time to do it. I don't have enough. I never have enough time. There's never enough hours in the day.
Is there a reason we only go until 1:30 today?
It's all about the required hours. Like you have,
Okay.
I don't even know. I think it's like 35 or 45 required lecture hours. And they all have to accumulate to that hour mark. So you can't go over, like you can't be 46 hours scheduled when you're only allowed to have, or when you're only approved by the Board of Nursing for 45. You know what I mean? So if that goes over, just like our tutoring session, it has to be voluntary. Like I can't mandate an entire class to do something that's outside of their required lecture time.
If she's
Would you
giving
be
up
able to
her
do some?
appointment with you today, if she's giving up her appointment today, I overslept on Friday and woke up and realized that I had missed our appointment. Could I take her appointment today?
That's up to Miss Bonnie.
Okay.
If you're just gonna go over everything before exam 2 or the final for exam 1 and exam 2, then she can have it. I'll look at the time 1 second to tell you what time it was. It was today at 2:45 to 3:45.
Perfect. I'll take it. Thank you. It's because I have to do the SAP, but I accidentally overslept on Friday.
That's totally fine.
Because I had to work that night.
Okay.
That's totally fine.
She'll have to send you a link though because it was a link for it.
Oh no, it's the Ring Central. You use your Ring Central link.
Oh, so it's the
Yeah.
same link.
Yep.
Oh, okay.
Thank you, Bonnie.
No problem.
So, any other questions, guys?
So this question is for one of your.
I don't know what the SAP is.
This is for one of your other hats, but would you happen to know when we are getting schedules? Since I know you do the clinical stuff.
Yeah, it should be going out today. I'm crossing my fingers. I was working, that's why, actually, Octavia, I was actually relieved that you didn't show up to your appointment on Friday because I was so stressed and working on the schedule for hours and hours and hours and hours. And thank God that Dr. Bowling is back from her vacation and she can help work things out. So they absolutely should be going out today, tomorrow at the latest.
I have a question. Will you be available to like answer emails, today if we have questions about the exam or whatever?
Yes, I should.
Okay.
I was just wondering if you were able to see the assignment picture that I resubmitted. You had said you couldn't see like my chapter something prep you that I submitted.
Which one? You got to give me more information than that, girlfriend.
That's a good question. I'm sorry.
There's 43 of you.
Let's see. I know. My chapter 52.
Let me stop recording. The shorter the recording is, the faster it is available for me